Are you able to hear me?
Yes, sir.
I think Dr. Bindu, you can go ahead. Dr. Kamachi is busy in OT. He is not able to join. So we'll go ahead and.
Good evening, sir. Sorry for the delay, sir.
You
I got
carry on,
stuck in.
Kamachi, with the work. I will manage.
Yes, sir. Thank you, sir.
Okay, thank you. Start, I think.
Yes, sir. Good evening, sir. My topic is a case presentation of a 46-year-old male poster for thymectomy, a case of myasthenia gravis. A 46-year-old male came to the hospital with complaints of progressive muscle weakness and fatigability for 3 years. So 1 minute. 1 minute, sir. 1 minute, sir. There is some construction work is going on near my home.
We are able to hear you clearly. You can proceed.
Yes, sir.
All right, I can start, sir.
Oh, she is quite audible, no?
Sir, am I
audible? Surrounding seems, sir.
No, but for me, her voice is quite clear and audible.
Shall I present, sir?
Yeah, finish up.
Yes, sir. A 46-year-old male came to the hospital with 1 minute, sir. 1 minute. Sorry, sir. I asked him to stop for a while, sir. Okay, sir. A 46-year-old male came to the hospital with complaint of progressive muscle weakness and fatigability for 3 years, impairing the day-to-day activities. History of presenting illness. Patient was apparently normal 3 years ago, after which he developed muscle weakness, which is slow in onset and progressive in nature. His initial symptoms were drooping of right eyelid and occasional double vision, especially in the evening. History of generalized muscle weakness, which increases or getting worse in the evening and improves with rest. No history of difficulty in chewing. No history of difficulty in swallowing. No history of slurring of speech. History of difficulty in climbing upstairs and lifting objects. No history of difficulty in breathing. No history of joint swelling. No history of skin erythema or skin changes. No history of weight gain, loss of weight, or intolerance to cold and heat. Past history, not a known case of diabetes, hypertension, coronary artery disease, chronic kidney disease, bronchial asthma, COPD, or epilepsy. Treatment history, patient is on pyridostigmine 60 mg Q8 hourly. Not fully controlling the symptoms. On tablet prednisolone 20 mg OD. Personal history, not a smoker, not an alcoholic, consumes a normal diet, has a normal bowel and bladder habits. Coming to the general physical examination, patient appears well nourished but fatigued. No pallor, icterus, cyanosis, clubbing, or pededema. Vitals, blood pressure is 20, systolic is 120/70 millimeters of mercury, recorded in the right upper arm in the upright position. Pulse rate is 75 per minute. Saturation is 98% and the room air in both sitting and lying down position. Systemic examination. Cardiovascular system, heart sounds are here, no murmur. Respiratory system, trachea is in midline, and bilateral chest movements is equal. Thoraco-abdominal type of breathing. Bilateral air entry is normal and no breaths. Per abdomen. Examination includes cranial nerve examination, which shows third nerve, lower motor neuron palsy, like including right ptosis and right eye diplopia is present. Motor examination, symmetric proximal muscle weakness is noted. The power included 4/5, which includes neck and shoulder and hip. Fatigability is noted on repetitive movement. Coming to the sensory system examination, it is intact. Reflexes are normal, which is 2+. case summary includes a 46-year-old male complains of progressive generalized muscle weakness with ocular muscle involvement with no medical comorbidities, is probably a case of myasthenia gravis, posted for thymectomy, coming under Osserman grade 2. Preoperative workup includes laboratory investigations, which includes routine blood tests, complete blood count, RFT, LFT, electrolytes and coagulation profile, and it also includes a thyroid function test and anti-nuclear antibodies, rheumatoid factor, acetylcholine receptor antibodies, and these are to rule out the autoimmune disease. Second, pulmonary function test, which includes vital capacity and forced expiratory volume. The third includes cardiovascular evaluation, including ECG and echocardiogram. Chest X-ray is must to rule out any aspiration or pneumonia. CT scan or MRI of the chest to know the extent and size of the thymoma. Electro EMG testing, which includes reduced compound muscle action potential to supramaximal twitch and decrement pattern on tetanic stimulation. Multidisciplinary consultation is required involving neurologist, thoracic surgeon along with anesthetist regarding surgical plan and post-operative care. The pre-op evaluation and optimization include assessing severity of myasthenia gravis, which includes which kind of muscle group is involved, whether bulbar group is involved or not, to rule out the risk of aspiration, the treatment and duration and response to the treatment. Respiratory function has to be evaluated. The forced functional vital capacity should be more than 2.9 liters. If it is less than 2.5 liters, it indicates high risk for post-operative failure. And if there is a severity of myasthenia gravis, we have to advise for plasmapheresis and intravenous immunoglobulins to neutralize the antibodies, to improve the muscle strength and to reduce the risk of myasthenia crisis. The medication is to be continued till the morning of the surgery. Steroids and immunosuppressants should be continued, tapered and discontinued in the post-operative period. The patient is to be admitted in the hospital 24 to 48 hours before the surgery. Ideally can be scheduled as early as the case in the morning. Pre-medications, which includes these patients have little respiratory reserve, hence the depressant agents should be given in caution in myasthenia gravis and to be avoided in the bulbar symptom patients. Hydrocortisone cover has to be given in the patients who are taking on who are on long-term corticosteroids treatment. And whenever possible, local or regional anesthesia is to be preferred. Airway management includes single lumen ET tube or a double lumen ET tube can be used based on the surgical approach for the thymectomy. Since thymoma is a mediastinal mass, can compress airway or major abdominal vessels in the mediastinum, hence to be prepared for a difficult airway management as well as cardiovascular collapse. For post-operative pain relief, thoracic epidural can be done. Induction is to be with a propofol or remifentanil. Myasthenia gravis patients are extremely sensitive to non-depolarizing muscle relaxants and are resistance to depolarizing muscle relaxants like succinylcholine. Hence, neuromuscular blocking agents can be avoided. Maintenance can be done with inhalational or total intravenous anesthesia. Inhalational sevoflurane is preferred more than desflurane. Monitoring includes neuromuscular monitoring whenever muscle relaxant is used. Arterial line is to be secured. Intra-arterial blood pressure monitoring is must. And we have to assess the patient for need of post-operative ventilation, which includes the forced functional capacity. If the patient has forced functional capacity less than 2.9 liters, history of myasthenia gravis for more than 6 years, if the surgery is a major surgery, existing lung disease like COPD, bronchial asthma, if the myasthenia gravis is grade 3 and 4, but if the patient is taking pyridostigmine more than 750 milligram per day. And coming to the post-operative care, according to post-operative ventilation criteria, we have to decide whether we have to continue the ventilation in the post-operative period or extubation is to be planned. If extubation is done, it has to be done when the patient is completely awake, obeying commands, able to protrude trunk or head left, for more than 5 seconds. It has to satisfy the extubation criteria. They are at high risk for postoperative pulmonary complications, which include atelectasis, pneumonia, or aspiration. Postoperatively, patient has to be monitored in a highly dependent unit or ICU care. Pain management has to be a multimodal pain management, and thoracic epidural if access has to be used. Medication pyridostigmine can be started orally when the patient is awake. Thank you, sir.
Okay. You have covered most of the points. You said it is a type 2 myasthenia gravis. What are the other types? Or how do you type the myasthenia gravis?
Sir, according to Osserman grading, we can divide the myasthenia gravis based on the severity, sir. There are 4 grades. Grade 1 is only ocular muscles involved. Grade 2, that is A and B. It's a mild disease, whether it's a whether the patient is tolerating the medication or it is not well responsive to the medications. Grade 3 is severe myasthenia gravis, and grade 4 is myasthenia crisis, sir.
I think grade 3 is an acute onset and grade 4 is continuation or worsening of grade 1 and 2. It is not the other way as you say.
Okay, sir.
And which type of patients will benefit by thymectomy? Why he has been posted for thymectomy? Which is the grade type 2 or grade 2 patients who benefit by thymectomy?
It's 60 to 70% of the patients, where if the patient is having ocular complaints and whether the patient is not responsive to treatment, they would be benefited with thymectomy, sir.
For thymectomy, there are 2 reasons why. One is they may belong to grade 3. This is occurring often. The second thing is there will be anti-thymal antibodies predominantly present. Then that is an indication to do the thymectomy. Okay? So, what are all the approaches can be done? That has to be mentioned in your answer. You said that depends upon the surgical plan, but you must mention there are several approaches by which we can do the thymectomy. What was the earliest method? What is the current method?
Transternal approach is used in
older method was to split the sternum and do it like a routine sternotomy for open heart surgeries, or at least upper part of the sternum were to be opened to approach the mediastinum to remove the mass. But nowadays they prefer a small cervical incision and do through a mediastinoscopy or video assisted thoracoscopy, and that is the reason why you have to place the endotracheal tube or the double lumen tube depending upon the surgical approach. That is a very important point that we have to remember. And if you want to avoid muscle relaxants, how can you place the endotracheal tube or the double lumen tube?
We can use induction agents like propofol. We can give a.
No, that is for making the patient unconscious, but reflexes may still be present.
We can use a lignocaine spray to the oral cavity and in the pharyngeal wall.
And that is saying 2% or 4%. We muscle relaxants commonly used nowadays. Are you able to hear me?
No, sir. Just now we couldn't hear you, sir. Just now.
Now are you able to hear me?
Now we are able to hear you.
Which relaxant is safe to use in cases of myasthenia gravis, if at all relaxant is needed?
Short or intermediate acting like cisplatin.
Name the drugs. Don't classify them or do it like that. What are the drugs which can be used safely?
Cis-atracurium, atracurium, or rocuronium can be
Rocuronium. Because rocuronium has got a reversal agent in the form of sugammadex. But if you use atracurium,
Sir, couldn't hear you, sir.
for reversing the
Not audible, sir.
Not audible, sir.
not audible. Okay. If you reverse segment, am I audible now?
Yes, sir. Yes, now audible, sir. No, sir. Atracurium undergoes Hoffman's elimination, as well as it is eliminated by the pseudocholinesterase and the.
Yeah, I agree that. But if at all reversal is you use the muscular monitor and the train is not free, can you use stigmin to reverse the? It's my
Yes, sir.
question.
Yes, sir. We can use, sir.
So, see, surgeon asked you for relaxation, saying that the chest is tight or some reason, and you give the use retracurium. But patient is not having adequate muscle recovery at the end of the surgery. Train of 4 is not satisfactory. So, can you use neostigmin and reverse the effect? That is the question. The other is it
No, sir.
audible now?
Yes, sir. Audible,
No,
sir. We cannot use without satisfactory TOF. We cannot use neostigmin for reversal, sir.
So what will you do then?
We cannot do anything, sir. We have to wait for some time to.
You have to
talk
ventilate
to.
the patient electively. That is the
Yes,
answer that you have to give. Don't try to reverse. Why you should not try to reverse?
because the junctions which the atracurium acts will not be available for neostigmin to act, sir.
Okay, I will go to share my screen. We will see the answer there.
Yes, sir.
This is a B cell mediated autoimmune disease where the antibodies bind to the receptor and almost destroy them. What other change happens in the neuromuscular junction apart from the destruction of acetylcholine? Change happens in the neuromuscular junction in patients with myasthenia gravis. My question audible to everyone?
Yes, sir. Yes.
Yes, sir.
The antibodies can also bind functionally molecules, including this MUSP receptors or muscle spectral specific kinases or lipoprotein receptor related peptide. And the other change that happens apart from the destruction or modification of the acetylcholine receptors is widening the synaptic cleft. The gap between the neuronal and the motor end plate or the muscle synaptic cleft also increases. And that is the reason why the traveling of acetylcholine also takes a longer time in these patients. And that is another reason for the muscle weakness. And autoantibodies to SHR disrupt function by receptor blockade or conformational changes in the receptor and complement activation, cross-linking, leading to increased degradation of the receptors. The alternate antibody targets disrupt the regulation maintenance of normal synaptic function. And this is also recently recognized as a life-threatening complication of some of the, there's an acquired problem. All the time we were thinking it is only a beta cell mediated autoimmune disease, but some of the newer cancer immunotherapies including pembrolizumab and other checkpoint inhibitors. They are all also causing a condition similar to myasthenia gravis. D-penicillamine may cause drug-induced form of the disease, which resolves after it's discontinued. So when you ask for history, this drug usage also has to be included in your history taking, because some of them would be a cancer survivor and they may be coming with this particular problem. So the history should include these drug usages and rule out other autoimmune conditions. You said in your description that this patient does not have uh, increased sensitivity to heat or cold, isn't it?
Yes,
Did you
sir.
mention that?
Yes.
Why did you say that?
Because more in 15 to 20%, these patients are associated with the thyroid hypofunction. So
Hyperfunction. More thyrotoxicosis is more common than hypothyroidism. So that is the thyroid dysfunction in the form of thyrotoxicosis is more common. So you must ask for symptoms of hyperactivity of thyroid rather than hypoactivity, and other comorbidities which are common to any person is also present in these patients. And thymic hyperplasia is usually with the early onset of the disease, and pre-op evaluation should include the type. If you understand the way five grades rather, type 1, type 2, A, B, and type 3, 4, you will know which groups. Type 1 is purely ocular, and 2 and 3 are the ones which affect the proximal group of muscles, and depending upon the acute onset or chronic onset, it is graded into type 3 and 4. And so especially find out whether there is a chance of aspiration, because once the bulbar involvement is there, then pulmonary aspiration is very, very important complication, which is the most threatening complication which can cause morbidity in the post-op period. So in order to avoid that, you can use a proton pump inhibitor or a histamine 2 blocker. Of course, we are not using this nowadays. Cimetidine has become obsolete now, but we are using pantoprazole or omeprazole, and prokinetic agent like metoclopramide can be given along with drugs which are used for treating the myasthenia gravis. So this is one of the important pre-op medications that has to be mentioned, and the avoidance of calcium channel blockers if the patient also has hypertension or any form of magnesium therapy should be avoided, because it can interfere with the muscle contraction. And the treatment, why we prefer pyridostigmine over neostigmine? Are you able to hear, Dr. Bindu?
yes, sir.
Why pyridostigmine is commonly used, and you have neostigmine also available as. Where else is this neostigmine used apart from myasthenia gravis? Huh?
It causes blood-brain barrier and receptor levels.
So you need it to go to the brain?
No, sir.
Yeah. Then why do you worry about going to the blood-brain barrier? You want the action only at the neuromuscular junction, that voluntary muscle group. Not even involuntary. Pardon?
Long acting, sir?
Longer acting, yes. Dosage can be, even though you are giving it the higher dose, it is longer acting compared to neostigmine. But where neostigmine is used in some conditions other than myasthenia gravis. What are the conditions where neostigmine is used by neurophysicians? Okay, try to find out that answer. One word about myasthenia crisis is important, because type 3 patients are more prone for crisis, and it can be precipitated by infection, and your surgery can also precipitate it. How, when you do a thymectomy, patient can go in for myasthenia crisis? You are doing thymectomy as a relief measure for patients suffering from myasthenia. But this surgery itself in the post-op, can it precipitate a myasthenic crisis? You can say yes or no quickly, because after I find the classes are going in for 3 hours. It is very exhausting for all of you. So from today, I have decided to stop my classes by two hours time, if we have finished the topic or not. Because you all seem to be getting very exhausted and some of you are missing from the class. I don't want that to happen. So I am trying to finish it as quickly as possible. If you respond fast, I will be finishing it faster also.
No, sir.
The reason is thymectomy does not produce immediate results. It takes longer time, at least 2 months to get the desired effects. So it is not an immediate cure. So patient has to continue with the pyridostigmine he is taking. So he cannot abruptly stop that. Okay, that is the reason why you have to know about this myasthenic crisis also. And it can affect the crisis at least once in their lifetime. And it may require a tracheal intubation and mechanical ventilation if it happens. And diagnosed by clinical, serological, and neurophysiological testing. And serum acetylcholine antibody and thyroid function tests are the first line of investigations, followed by the other antibodies which may be present. And when the treatment part of it, there are 4 approaches. One is symptomatic treatment, just giving pyridostigmine to improve the level of acetylcholine and improve the muscle strength. The second is, because it being an autoimmune disorder, you can use immunosuppressive therapy like corticosteroids and other agents like mycophenolate, your cyclosporine, all the other agents which are used as an immunosuppressor or immunomodulator after a transplant, they are all used here also. And rapid short-acting immunodilating treatment like you can use for a crisis, you can use immunoglobulin as a IV preparation, IV immunoglobulin, or you can do plasmapheresis or plasma exchange to remove the quantum of antibodies. And thymectomy is indicated in patients who have a huge thymoma, which may be the cause for the myasthenia gravis, and that may sometimes even result in the cure of the patient. And before taking up any patient for surgery, whether it is for thymus removal or incidental surgery, you must always predict the likelihood whether the patient will require any post-op ventilation or not. And for that, we have some criteria. Duration of the disease more than which is severity, other coexisting lung disorders, and if the vital capacity is less than 2.9 preoperatively, and if the surgery is going to be a major cavity surgery, or history of previous myasthenia crisis at least once, and presence of anti-acetylcholine antibodies. If all these things are present, these are all called Leventhal scoring system, and that tells you about the need for that. So you must counsel the patient that he may be put on ventilator post-operatively. So patient, when he is being examined pre-operatively, based on these criteria, and the reason why you, after the surgery, you reverse the patient, or you wake up the patient, but you may continue to ventilate him. So that is the reason why he has to be counseled and told that he has to be ventilated. And the surgical techniques, the traditional median sternotomy is the old method, transpherical approaches, and minimally invasive video assisted thoracoscopy, and even robotic assisted thymectomy, which is the most current minimally invasive technique. So this was the original traditional medial sternotomy made at the upper part of the sternum. This is the transcervical minimally invasive approach where an incision is made. The reason why you have to know about the surgeon's plan of the technique of anesthesia is, depending upon that, whether you can do relaxant may on either a TIVA or a inhalation agent method. Otherwise, sometimes you may need to require a muscle relaxant also. And this is the endoscopy where you have, and the robotic approach. You can see the robotic docking systems in place. And so, depending upon that, you have to use your technique. And in robotic, they require totally still patients because any movement, major injury to blood vessels. So these conditions may require judicious use of your muscle relaxants. In that case, at the end of the procedure, patient may not have the full power to breathe normally. So you may have to maintain them on elective ventilation for a few hours till they get out of the catheter. So coming to the conduct of anesthesia, induction, you can do the standard induction with propofol or opiate in the form of, as she said, remifentanil. But avoid using more stronger opiates because that may add to the post-operative depression. As much as possible, avoid use of any muscle relaxant, even to place an endotracheal tube or a double lumen tube. So if at all needed, these are the 3 muscle relaxants which can be used. And always placing a thoracic epidural can be used for both intraoperative and post-op anesthesia. Tracheal or double lumen tubes can be placed after 2% xylocaine or 4% xylocaine spray into the laryngotracheal area, depending upon the surgical technique that is planned. Coming to the maintenance, you can use with propofol and remifentanil through the procedure. And monitoring, apart from routine monitoring, neuromuscular junction monitoring is very helpful in assessing the muscle relaxant effect if at all you are going to use that in case of emergence. Ensure full recovery of neuromuscular function before emergence. Avoid the cholinergic crisis. That is the reason why avoid the titrated doses of opioids to avoid respiratory depression. Elective ventilation if planned preoperatively for the criteria Leventhal scoring system that is planned. Okay. Discussion on Myasthenia gravis. Any questions or any doubts on that?